order. Good morning. I call this meeting of the Public Accounts Committee to order. This morning we have the Department of Health and Wellness and the Nova Scotia Health Authority with us to discuss the mental health strategy. Would ask everyone to place their phones on silent so we don't have interruptions this morning. We'll begin with introductions, starting with Mr. McKay.
Good morning, Hugh McKay, MLA for Chester St. Margaret's. Welcome.
Good morning, Brennan McGuire, Halifax Atlantic.
Benjamin Jessam, Hammonds Plains, Lucasville.
Good morning, Suzanne Lonas-Croft, Lunenburg.
Good morning and welcome, Gordon Wilson, MLA for Clare Digby.
Good morning, welcome. My name is Tim Houston. I'm the MLA for Pictou East.
Good morning, Dave Wilson, MLA for Sackville-Cobequid.
And I'm Lisa Roberts, CMLA for Halifax Needham.
Alan McMaster, MLA for Inverness, and your chair. We have the Auditor General's office with us this morning.
Terry Spicer, Deputy Auditor General.
And we have many witnesses today. We'll start on the right with Ms. Peach and just carry on down the line.
Good morning, Lindsay Peach. I'm the Vice President, Integrated Health Services with the Nova Scotia Health Authority.
Good morning, Janet Knox, President and CEO, Nova Scotia Health Authority.
Good morning. My name is Sam Hodder. I'm the Senior Director for Mental Health and Addictions with the Nova Scotia Health Authority.
Good morning. Denise Perret, Deputy Minister of Health and Wellness.
Dr. Charmaine McPherson, Executive Director for Primary and Acute Care Branch with the Department of Health and Wellness.
Dr. Alexa Bagnell, Chief of Psychiatry at the IWK.
Jocelyn Vine, VP of Patient Care and Chief Nurse Executive at the IWK.
Maureen Brennan, Director of Mental Health and Addictions at the IWK.
Good morning, Jennifer Heatley, Project Executive Health Promotion at the Department of Health and Wellness.
Thank you. And we will have opening comments, I believe, from a couple of the organizations here at least. Who would like to begin? Ms. Perret? Ms. Perret.
So good morning. Thank you very much for the invitation to be here on the topic of mental health and addiction. Providing access for Nova Scotians to the healthcare services they need is a priority for this government and for the Department of Health and Wellness. Key in this priority is the government's goal and investment in strengthening and improving access to mental health and addiction programs and services. For too long, mental health has been the second cousin of the healthcare system. And that's true for this province and throughout Canada. And we see the effects of it. There are challenges in the system. Demand is high. Wait lists are too long in some cases. Some specialists are hard to recruit. People don't always know where to go for help. But this situation is starting to change. We're at a point as a country where there's a growing recognition that mental health needs to be valued and have the same priority as physical health. The challenge is that mental health addiction services have often been brought into the public health system in an incremental and often sometimes ad hoc fashion. It's a bit like the prescription drug circumstance, that we have a broad landscape of services that are publicly paid for, privately paid for, that might be provided through employer benefit plans. And as we facilitate the move to a much stronger, publicly funded system of services, we're focused on a number of things. We know that we have to create larger capacity in the public system to facilitate and enable better access for all Nova Scotians. This includes hiring more clinicians and putting in place effective navigational services. We also want to connect and integrate with nonprofit service providers because this expands system capacity and helps to build a more comprehensive and cohesive system. We need to have a fulsome continuum of services from health promotion through early intervention and treatment through to addressing and treating complex mental health and addiction needs. And an example of this effort to build the continuum are the steps being taken to facilitate connections between youth health centres, schools plus clinicians, and primary care services for children and youth. As well, we need to determine how emerging virtual health technologies can play a role in this space, because there is very interesting developments happening on the technology front with encouraging outcomes and results. And we need to ensure that we make the right investments in this area and that these investments give us positive outcomes, that they're safe, and they deliver the expected benefits. So there's many individuals and organizations that are part of this work to build a more comprehensive system. Some are here today, and others are in the community doing this work. Very briefly, the Department of Health and Wellness is the policy and funding arm of the system, and the minister is charged with setting the strategic direction for the health system. The two health authorities that are here today are responsible for organizing and delivering the health services. Two departments that play important roles that aren't here today are the Departments of Education and Community Services. There's also a tremendously important contribution being made by researchers and innovators, and we need to maintain and grow this connection. And two that you will be aware of is the work of Dr. Stan Kuchar, who provides important expertise and advice to the Department of Health and Wellness and the Minister. And I would also mention Dr. Patrick McGraw, whose work in establishing and growing the Strongest Family Institute has provided accessible and practical support to youth and families. So Nova Scotia is fortunate to have dedicated and skilled service providers in its nonprofit sector and in its public health authorities. And we also have organizations like Lang House, McPhee Workshop, the Phoenix Centre that provide service delivery models that merit support and possible growth. Finally, within all of these organizations, we have dedicated staff and workers who are on the front lines doing true public service, and I want to acknowledge their work in delivering quality mental health and addictions care to Nova Scotians. So again, we appreciate the opportunity to be here and to be part of this discussion. Thank you.
Thank you, Ms. Perret. Ms. Knox.
Good morning. Thank you for the opportunity to be here. This is a very important subject for Nova Scotians. Leading healthy, flourishing, and productive lives are top priorities for our citizens. Positive mental health and living a life free from the harms, risks, and injuries associated with substance use and gambling are fundamental to reaching this goal. Without mental wellness, hope, and the possibility of recovery, it's hard for people to live healthy lives and contribute to their community in a meaningful way. The prevalence of mental health disorders and harmful substance use is high among Nova Scotians. In any given year, 1 in 5 people are living with a mental health problem. 1 in 7 will experience a substance use problem at some point in their lives. When we include families, caregivers, and communities, every Nova Scotian is impacted in some way by these health conditions. We know some people and their families are waiting too long for the care and support they need, and sadly many people who need services are either not getting the help they need or may not ask for help at all because of the pervasive stigma and discrimination that continues to exist. Over time, we have seen changes in the people who use our services, the complexity of their needs, and how they may best respond to support. We are building ways to match those needs with strengthened community supports, technology to maximize access to specialists, and mechanisms to evaluate the impact on recovery and well-being. Our team is focused on improving the experience of patients, clients, and their families while helping to support their road to wellness and recovery. Historically, there have been some fairly fundamental differences in how mental health and addiction services are provided and supported across our province. Our task as a health organization has been and will continue to be to work with our leaders, with providers, funders, and consumers to examine, implement, and evaluate the changes that are required in our system so that it is better integrated around the needs of our people, that promotes positive mental health and supports recovery for all. The document titled Milestones on Our Journey, Transforming Mental Health and Addictions in Nova Scotia that we included in your packages is intended to serve as a framework to help further guide the development and implementation of a provincial model for promoting positive mental health care and support in Nova Scotia. In planning, we have reviewed the analysis of others of mental health and addictions in Canada and across our province. We have taken the opportunity to ask profound questions about the people we serve. What services should we be offering, and how to ensure those services are based in evidence and responsive to the individual, to their families and their community. The collective message is that the system change is long overdue, and we need to produce much better data in order to make decisions to improve our programs and results. So our commitment is to ensure that people and their families have access to a fully integrated continuum of high-quality services and supports, from health promotion to intensive treatment and support. Movement within the continuum of care must be smooth, patient and family-centered, and our relationships with communities strong to help people be well and stay well. People and their families have better and timelier access to a range of care and supports in their community and in our schools. We must focus on reducing stigma and discrimination, and we must focus on promoting positive mental health, hope, and recovery for our citizens. The work we have begun will take time to do in the way that Nova Scotians deserve. We are making considerable progress, yet there is much more to do. We are and we will continue to move forward with a well-defined direction, excellent partnerships, and the drive to achieve excellence. Mental health and managing harmful substance use and gambling requires the attention of many sectors of our society. Beyond our services, it's clear that workplaces, our many partners, our communities, and many others can have a positive impact. I would say we want to make sure that our impact is purposeful, that our goals are clear. We all have a part in this to ensure success for Nova Scotians. In closing, together with the IWK and the Department of Health and Wellness, we are designing a responsible, accessible, effective public system informed by evidence, and one that must be easy to navigate while keeping the recovery, well-being, and positive mental health of individuals and their loved ones at the centre of all of our work. Thank you.
Thank you, Ms. Knox. So we have the Health and Wellness Department, the Nova Scotia Health Authority, but we also have the IWK, and we will have opening comments from them as well. We will hear now from Ms. Vine.
For the opportunity to discuss the important topic of positive mental health and addiction services for Nova Scotians. Providing a supportive environment early in life is critical to healthy growth and development. In addition, early supports focusing on emerging mental illnesses should be readily available in ways that suit children, youth, and their family, and maximize their ability to stay engaged and positively functioning in their normal activities. The needs of children and youth require particular attention, as demonstrated in the 2017 UNICEF report card on child well-being. The report highlighted that Canadian children are not doing as well as those of other wealthy countries, particularly in the areas of health, protection from violence, and overall well-being. Progress on poverty and food security are key to creating a healthy future for children, youth, and families. We recognize this challenge on a system level and work closely with government and community departments such as community services, justice, and education to respond to the needs of families. The IWK Mental Health and Addiction Strategic Plan has created extensive program transformation to redesign our internal services to ensure they provide well-coordinated and evidence-based continuum of care that is responsive and effective in meeting the needs of children, youth, and families. We have added a major focus on creating partnerships and opportunities to collaborate outside of our services and in partnership with other key community providers who work with children, youth, and families. Through strong collaboration, we've been able to expand our reach within the community and benefit from the expertise of other care providers to better meet the needs. The IWK works very closely with the Nova Scotia Health Authority, realizing many opportunities within a provincial model of care for children and adolescent services. Through this work, we have endorsed a stepped model of care that matches service levels to the treatment need. As well, we work with our many community and government and health partners. The IWK is focused on working with children, families, and youth to design services that best meet their needs as close to home or school as possible. We are working collaboratively to strengthen the important connections to ensure smooth and safe transitions and to share opportunities to improve. Inpatient and intensive intervention programming is available when needed. We are working closely with the Department of Education and Early Childhood Development on the recommendations from inclusive education, and we welcome the opportunities provided through this shared focus on the needs of children and youth. Working together is the path to success. IWK has been making transformational and evidence-based changes to our mental health and addiction services and programs in close collaboration with NSHA to ensure that services for children and youth, not only at the IWK, but throughout Nova Scotia, are the best they can be. These changes have been based on 5 key areas. They include the principles and practices of patient and family-centered care, the implementation of the choice and partnership approach, which works on the goals of the child and family, evidence and best practice in partnership for delivery of services, co-design of services in partnership with patients and families, and the principles of trauma-informed care. In addition, we have introduced significant investments in improvement methodologies within the program, and we have been able to redesign processes based on what patients and families and our teams tell us are needed. And through these project investments and the expertise of our teams, we've been able to significantly improve timely access to care, and we continue to spread those improvements across our programs and clinics. Another important area of focus is ensuring that our team members are supported and have the learning and research opportunities they need to build successful careers right here in Nova Scotia. Our work is showing very positive results as we begin to improve access and the ease of navigation across the continuum of care so that children, youth and families can move smoothly across services and back to their everyday lives with the supports they need within the local mental health and addictions teams and within the school environment. We must continue closing the gaps for children and youth across Nova Scotia. There's much work ahead for the IWK and for NSHA and all of our partners. We are focused and committed to continued transformation toward positive mental health and excellence in care and services. Thank you.
Thank you. We will start with Mr. Houston of the PC Caucus for 20 minutes.
Thank you, Mr. Chair. Thank you for the introductory comments and for being here this morning. Ms. Knox, the deputy referred to needing to expand capacity in the system, clinicians, doctors. I have to ask you off the top, why wasn't Nova Scotia represented at the recent recruiting seminar?
Ms. Knox.
Thank you. Are you referring to the education session for rural family physicians in Newfoundland?
Yes.
Yeah, oh, yes. We have a robust recruitment strategy for physician recruitment, and what we have found in our work with residents and learners who are in medicine, that direct contact is the best approach. So our strategy was a personalized direct strategy with the residents in Atlantic Canada. To be present with them alone, and so we went to Newfoundland to meet with the residents 2 weeks before that session.
Okay, so you didn't see the value in that particular session.
The decision was made that our best value would be in independent, direct talk with them. The
Premier insinuated in the House during question period that he was basically appalled that we weren't represented. Do you disagree with the Premier on that?
I can understand.
Is he misinformed?
I would not comment on the Premier's views, but what I would say is we make the best decision that we can in terms of where we're going to get the best return, and that was the decision that we made. And I truly do understand in terms of people thinking, why were we not at every opportunity? We have a very robust strategy, and we'll be next month in another national meeting where 3 times the number there, rural physicians, but also nurse practitioners and medical students go to that session in Ontario. Okay. So you make your choices. So thank you for your question.
So you maybe have a different strategy than all the other provinces, I guess. They were represented. We weren't, and just pretty close geographically to Newfoundland. But I guess we'll just, if I may, I'll just leave it at that. You had a different strategy than everyone else.
We do believe we need a different strategy than other provinces because we are actually in direct competition with the other provinces. So you need to think about where you are, if sitting next door to a province or with all of them there, or being with spending dedicated time with individuals to help them see how important they are to Nova Scotians and that we really want them to be with us. So that's the decisions you make.
One might argue that a personal contact 2 weeks before and then a follow-up at a major conference might have made sense too, but we'll leave that at that for now. Wait times for mental health adult community-based services are pretty high. We're talking about services that can assist with anger management, anxiety and stress management, depression management and recovery, and the wait lists are just too long for these. You referred in your comments about the services that the province should be offering. I assume that these types of services would fit that category. The province should be offering these types of services. I see some nodding in agreement. So they should be offered. The wait times. I went to the website and picked up the wait times between July 1st and September 30th, 2017. And these are the wait times. I want to read them off, if I may, for Cape Breton Regional, 363 days. St. Martha's Regional, 215 days. Valley Regional, 114 days. Hants Community Hospital, 95 days. Aberdeen, 91 days. Cumberland Regional, 83 days. Cole Harbour Place, 63 days. Inverness Consolidated, 52 days. I added that one for you, Mr. Chair. Pretty long wait times in my mind, and you referred in your comments that the commitment, your commitment to the people, is that families should have access to the services that they need. Are these wait times too long, and what is an appropriate wait time that would be acceptable to the Health Authority?
Thank you for the question. I'll start, and then I'm going to ask Sam Hodder to talk about the wait times, because she has the data and information. And what I would say to you, thank you very much for raising this issue. What we're talking about in terms of, we do need to understand what the needs of Nova Scotians are, and we need to develop our services so we can respond appropriately to those needs. Across this province, there was, as our deputy has said, our past has been an incremental offering or enhancing services, but not in a uniform way, so that we can say that this service is uniformly available across the province for Nova Scotia. So hence, when you talk about different wait times for services, it's because our history has been not a plan to that access would be the same across the province. So I'll ask Sam Hodder to talk about the wait times and what we're doing.
Ms. Hodder.
Sure. And are the wait times too long, and what is the appropriate wait time?
I'll take that.
Sure.
So the wait times are too long. So I just want to acknowledge that. Particularly, we know that they're waiting too long, and the Nova Scotia Health Authority, in collaboration with the IWK, are committed to changing those wait times. One of the ways, and I guess what I would say is that wait times are one measure in terms of the overall performance of the system. Through our planning efforts that have been identified within the milestones report, we've made a commitment, as well as the Department of Health and Wellness has made that commitment, to invest additional resources into our community-based clinics, which are what those wait times are representing on the provincial wait time site. I would like, though, to speak specifically to the problem with the way the wait times were historically reported. Very disjointed and variable across the province, meaning that the bands and the level of urgency or priority wasn't necessarily reported on. So those wait times don't distinguish between triage level or need of our person's need. So they don't reflect urgent wait times. They don't reflect regular wait times. And so our commitment is to look at the bands of the wait times and putting in appropriate benchmarks that are linked up to national level standards in terms of what those wait times should be. So we've made a decision to move to a two-band system, which is in sync with where the IWK is as well. So our urgent would be 7-day wait, and our regular would be 28-day wait.
Okay, seven days for urgent and 21 days. 28. 28. So at the moment, so Aberdeen 91 days, some of those people are urgent and they're waiting 91 days, right? That's what's happening right now. Is that true?
I'm not sure how you would know whether or not that they're urgent or not.
So the information is not available. So how long will it take to transition the system to this new wait time system?
So we've already started to implement actions in terms of identifying our information system to be able to number one, record those wait times. There was many different ways that people across the province were registered, and the way that the wait times were inputted into our actual data system. However, there's also things that we need to improve on in terms of our system level change from a clinical perspective and a triage perspective for people who are accessing our service provision. So we intend, or I should say our target for reporting on those provincial wait times will be Q1 of this year, and we will have those available in August.
Okay. Have you, Ms. Knox, have you read Todd Leder's book, It's Not About Us?
I have. I read fast.
And does I've read the book, and it seems like he makes some good points. We don't need to recreate the wheel. They were already doing some good things in certain areas of the province. Is his book have validity to your mind?
So what I would say is that we are doing lots of good things around the province, and we want to maximize all of that. So we make when we talk about evidence, we need to be open to all evidence and use what others have learned and maximize that. That's our best resource. So whatever good evidence is available, this is not about recreating. There is a lot of work done in this province and in Canada. Our issue here is, as we've been saying, is that we need to have a plan that says all Nova Scotians should have access, doesn't matter where you live, and use our best evidence to create those services across our province. So yes, we use all evidence.
Do you use Todd Leder as a resource?
We have not consulted with Todd Leder recently.
Okay. The deputy referred in the opening comments to a much stronger publicly funded system, and Ms. Knox, you referred to working with the funders to improve the system. So obviously that's a big thing. Who's going to pay and how much? The Auditor General stated that the mental health budget is around $255 million. The Premier said that that budget is $287 million. In budget estimates, when discussing with the minister, it was indicated that the budget for mental health services or addiction services totals about $206 million. It seems to be, you got the Auditor General saying one thing, you got the Premier saying one different, you got the minister saying something different. Can you tell me how much is the department spending on mental health and addiction services?
Well, I think that's a question for the Department of Health and Wellness. So I would just say our budget would refer to the services that we provide. And as our deputy has said, mental health services are provided in schools, in communities, in hospitals across our province. So there are different budgets. When Nova Scotia Health Authority talks about our budget, it is the budget that we have to provide the services for which we are accountable.
How much is that?
Ms. Peach?
The budget for 2017-2018 for the Nova Scotia Health Authority is $172,855,000, and that's for mental health and addictions.
172 million. Okay, Deputy. The Auditor General referenced a number of 255 million. The Premier called the number 287 million. The Minister called it 206 million. We now know that the Health Authority believes their budget's about 172 million. As the Deputy, how much is the province spending on mental health and addiction services?
Ms. Perret.
Thank you. The estimates, and I'll give you some of the component parts, the number would be $287,097,900 is the budget for mental health and addiction services. Some of the larger items in that are inpatient, which is over $56 million. We have community mental health, which is over $96 million. We have physician services based on psychiatry, over $50 million. We have mental health, pharmaceutical and drug costs, that's over $30 million, and then it breaks down a bit further. But when you add those type of component parts together, it is just over $287 million.
Okay, thank you. So I do want to go back to the community services elements, because that's where the wait lists are so long. So does the department or does the health authority have, is 50 million, is that enough, or how much do we need to spend to get those wait lists down?
Ms. Knox?
So it's probably, it's what the question probably is how much what do we need to do? So I think we'll answer that question by talking about what our investments have been in the past year and what we've done with that. And I'll ask Lindsay Peach to start with that.
Sure.
Ms. Peach?
So I think to answer that question, it's there's really two considerations. One, how efficiently is the current system working in order to address the wait lists, and secondly, what resources are actually required to meet the needs of the population. So it is a twofold approach that we need to take. I think certainly, as we've spoken about already, the work that's happened as part of our health services planning to really plan for a stepped care approach for mental health and addiction, so that we're able to provide the support to individuals who need that level of support, and also work with our community partners who are able to support individuals who maybe have a lesser level of need or able to support themselves. From a community clinic perspective, as Sam's indicated, the wait times don't reflect individuals in urgent need. So
we don't know that. Sorry, I just want to be clear on that, because what I took from Ms. Hodder's comments was that we don't know that. We don't know if people that have been waiting 91 days at the Aberdeen are urgent or not urgent. Are you insinuating that we do know that?
Sam can clarify.
Ms. Hodder?
I think you misunderstood my comment there.
It happens.
Because I wasn't saying that we don't know that. I was saying that to make the assumption that we don't know that, but that's inaccurate. So our central intake across each of our areas, or each of our zone management areas, has established significant triage criteria that distinguish people on their level of care needs. And so they would be triaged in accordance with level of urgency or level of priority based on their presenting problem, and then matched with the appropriate level of care. So that clinical decision would be happening at that clinical interview at the intake level. And that is currently happening right now.
Okay, and when did that start?
We had started that, and it was a bit of a phased approach, but I can give you an example. Within Cape Breton, because of the pressures that were there in relation to the wait times, last year we actually looked at the system within the industrial Cape Breton area and implemented specific triage guidelines 1 year ago, borrowing actually from the northern zone and the work that they had commenced about 6 months prior to that, and identified the specific triage criteria there. And we have made significant improvements in relation to the intake that's done in the clinical assessment, as well as the urgent care needs within Cape Breton.
Okay, I'll come back, but that's important, so thank you. So the wait times that I found on the website were up to September 2017, so they're a little dated for sure. They were Cape Breton Regional 363 days. So I guess since then the system has changed. What's the wait time at the Cape Breton Regional now at the various triage levels that have been initiated?
So I can speak to that. It varies by clinic of service delivery. People in Cape Breton were waiting too long. Right now, I had consulted with our colleagues back in preparation for today's meeting, and the standard of the urgent criteria within 7 days after the clinical interview is conducted at intake is being met.
7 days, okay.
For urgent level of care.
And the standard for the 28 days, is that?
The standard for the 28 days is not being met in Cape Breton.
Okay, and do you have a number as to where we're at?
It varies between 7 months and 10 months.
Okay, okay. Do you have similar numbers for like the other, like Aberdeen and
I don't have those.
Okay, is that something you could get and provide to us? Like the Aberdeen you mentioned, when you said Northern was doing this even before Cape Breton Regional, I assume that's the Aberdeen.
Yeah.
And so they would have these numbers.
So what I would say to that is our commitment is going forward is that to look at producing those reports for August in relation to our first quarter this year. There was significant amount of work and action to think about that from a provincial perspective. The other piece to this is around our access and navigation project, which is requiring a sort of a provincial approach to conducting the triage and then matching the person's needs with the available services in the community.
Okay. So is it your belief that these wait times from September 2017 are much improved across the board?
I can't speak to that, but when we do have the evidence to support whether or not that they're being met or not met, we will provide that.
And I only have a little bit of time here, but which ones of these are using the new triage system? You say Cape Breton Regional. Is St. Martha's Regional using the new triage? And Valley Regional?
They're not.
Okay. And Hants Community?
No, they're not.
Okay. Aberdeen is, you mentioned. Cumberland?
Northern zone is, yes.
The whole northern zone is, okay. Cole Harbour?
Northern zone and eastern zone, the two zones.
Okay, northern and, okay. So Inverness?
Yes.
Okay, okay.
Still have about 30 seconds, but if you'd like to finish there, that's...
Thank you.
Okay, thank you. Move to the NDP Caucus and Ms. Roberts.
Thank you very much. My first questions are going to be for the Deputy Minister related to health funding and the transfer from the federal government. This year, the increase in provincial health funding from the federal government was 3.5%, and we're expecting that will drop to a floor of 3% annually for at least the next 8 years. According to a study conducted by the Institute of Fiscal Studies and Democracy at the University of Ottawa, the bilateral health funding deal that Nova Scotia signed is going to result in a loss in the long run because the macroeconomic healthcare cost drivers are expected to outpace the growth rate in the health transfer over the coming decade. I guess my question is there a written agreement that we can see where the details of that bilateral health deal are spelled out?
Who do you wish to ask the question?
Sorry, that is to the Deputy Minister.
Okay, Ms. Perret.
Thank you. Important question. The bilateral agreement is not yet public. We're still negotiating some of the terms with the federal government with respect to the projects that are being included in that. And an important part of that, and you've heard the importance from earlier discussions here, is on measurement, how we're measuring, monitoring, and determining outcomes. So that information will be out a bit later this year.
Can you explain why there are publicly available agreements and targets and commitments from New Brunswick, Newfoundland, PEI, and the Northwest Territory, and yet Nova Scotia that signed a deal earlier is still negotiating the terms?
My understanding is that most of the provinces are still negotiating with the federal government on their individual bilateral agreements. And quite frankly, we want to make sure that we're using that investment money wisely, and it gives us a space to try some of the new virtual technologies, and it's going to be important that we have the right measurement and monitoring criteria in place.
How do we know even that this funding is going to continue at a particular level if there is no written agreement at this point?
So the funding agreement itself was set out for 10 years. It's broken into two parts. The bilateral agreement includes the identification of the projects and the outcomes anticipated by those projects in 2 5-year chunks. You have to reapply for those projects after 5 years. But the funding commitment itself has been set out, and it's a 10-year commitment. We're not negotiating the amount of money. That's been determined at this point.
Do you have a date when we can expect, a final agreement, and that Nova Scotians get to see what we've committed to, what those commitments are?
So I don't have a specific date. We would like to have that out as soon as possible, and the feds would like that as soon as possible. So everyone's motivated to conclude this. The back and forth is actually quite constructive and instructive because, again, as you've heard, it's important to get some of the measurement tools right and to make sure that we undertake projects that are going to be, that are going to have the outcomes for the population that we're seeking.
So there was money that flowed to the province under that agreement this year and for this budget year coming, correct? Can you provide a breakdown of how much of that targeted federal funding will be allocated specifically to mental health this year and where it will be spent?
So I don't have those figures with me today. We have those figures and I can provide them. So I will undertake to make that to bring that information forward.
Okay. And can you give me an example of, you know, as you're negotiating, what sort of performance measure are we looking at that would actually, you know, reassure Nova Scotians that we're moving towards positive change in the mental health system? So,
for example, and this is tentative because it's not been approved, but I mentioned earlier the work of Dr. Pat McGraw on the Strongest Families Institute. Well, that work is expanding into caregiver support. And being done through virtual means and support groups. And so we're interested in whether we could incorporate that type of technology into the work we're doing to support people in the community, we support caregivers financially. We want to expand those types of supports both through technology, through technology that monitors people in their home or that helps with lifting patients and the like. And because caregivers have anxiety and depression, we're interested in how we can support them in that space as well. So these are the type of initiatives that are under discussion. Some of these initiatives are developmental. So the measures are, how do we know, as I said before, that it's an appropriate tool, that it's a safe tool, that it gets the outcomes that we want.
And just to make sure that I understand things correctly, $287.8 million over 10 years is targeted to mental health. Is that mental health and addictions, both health authorities, I'm imagining, or?
So I have to check the number because I don't have the exact number before me.
Okay.
Yeah.
Can you provide any insight into why the funding is not being distributed evenly over the 10 years?
So I believe that the federal government came in this, it gave us a bit of startup time before you sort of get to cruising altitude, as I would say. So I think that's the primary reason.
Okay, thank you. I reviewed, you know, maybe not entirely in depth, the milestones report that was provided in our package. I guess that came from the NSHA. And part of me is just trying to understand how that relates to the work that engaged 1,200 Nova Scotians over years, which was the Together We Can mental health strategy. So maybe first, I mean, I think this is, like, as a relatively new MLA, this is one of my sources of frustration. That work that is done by one government can seem to be, with a change in government, irrelevant, even though that work actually did not belong to the elected officials. In fact, it belonged to all the community agencies and the bureaucracy, you know, the public service that worked long and hard on that work and was in service of Nova Scotians. It was not like a Liberal report or an NDP report. It was a mental health strategy for Nova Scotia. So first, quickly, can somebody explain to me what the milestones report is and how it builds on or relates to the Together We Can mental health strategy?
Ms. Perret.
Thank you. I really appreciate that question. I agree with you. I think too often really good work gets done and it gets shelved, and the election cycle is disruptive in terms of building a system. And one of the decisions that we made in looking at the type of investment this government wanted to make and how quickly we could put that in play, and what documents that are policy and strategic documents were in place, is that this wasn't a time for people to go to their cubicles and write another policy document. That this was, we needed to look at the landscape we have and knit it together. Because I want to say that documents like the Together We Can document is an extremely well done document. When we looked at the principles and the values in that document, we're like, they are still relevant and they need to carry forward. So we want that document to stay alive, and certainly the front end of it to guide the work going forward. That work's been complemented by the efforts of both health authorities, and the department played a role in the milestones document, which gives you a stronger in-depth look at what some of the current research is in the area, what organizations are in play, what the clinical structure is, which they would call it the pyramid, the tiered system, which I would call part of the continuum of care. And so it sets out in a much more specific fashion where we go off from those principles and values, and together we can, into a more structured clinical approach. And then we have the benefit of the Minister's Advisory Committee on Mental Health and Addictions, which is still guiding the work of the department and the strategic view with both the recommendations it makes, and it continues to advise the minister, and then Dr. Kuchar's report on Cape Breton, which all plays into that. So if you have the mandate commitment for the minister and those documents, you really have the strategic overlay for the system.
Okay, thank you. At Public Accounts on February 17th, 2016, then Deputy Minister Peter Vaughan said that Nova Scotians are experiencing greater access to mental health assessment, treatment, and care in their own communities, which suggests that evaluations of changes to the mental health system have already been completed. Is that true? Has there been evaluation of changes made under the mental health strategy?
So the focus on measuring and monitoring and measuring is a really important point. And it's part of and I think probably what Dr. Vaughan is referring to, at least in part, is that the restructuring of the department after the consolidation of the health authorities was to focus on how we monitor the system, how we stop looking at inputs as much as we do and start looking at outputs and outcomes. And so that work is still in play. You heard the discussion on how we need to be much more diligent and have a robust, more informative system of measures on wait time so that they actually have meaningful information for us. And so I would say it's not a measured system that's complete. It's still being built in progress. The work on wait times is one example of that.
And so just to be clear, there has been no evaluation done of actions coming out of the Together We Can strategy. Is that accurate?
I'm going to refer that to Dr. McPherson if she wants to add to it.
Dr. McPherson?
I'm not quite sure what you're meaning in terms of evaluation, what level of evaluation. So we have looked at the strategy and the various components in terms of have they been met? Have we delivered on those? What's at play? And we are looking at the entire strategy from an evaluation viewpoint in terms of reflection on the components and have they been brought into the public system.
I guess what I would be interested in is there an evaluation that has been shared with the minister, because during the Committee of the Whole House on Supply, in conversation back and forth with the minister, when our health critic asked about evaluation of the Together We Can, the mental health strategy, the minister said, when I talk about the review of the Together We Can strategy, it's really my review work that I was doing reviewing the document, not a formalized review, my assessment of the document. So it seems that there hasn't been, I mean, is there a review of the document, or is there an evaluation of the work that has flowed out of the document? And if there is such an evaluation, can it be shared with the public? Can it be shared back to the 1,200 stakeholders who participated in the development of the document?
Ms. Perret.
No, I appreciate that clarity. And the short answer is no, there's not a formal evaluation document that we could share with you. It is the subject of much discussion, and it informs a lot of the work that we do, but we are still building a system that's much more outcome focused.
Okay, thank you. According to the master tracking dashboard of the mental health and addiction strategy, work on a sex, gender, and diversity review of mental health and addiction services had still not been started as of October 2017, and nor had collection and monitoring of alcohol, drug, and gambling data. Ms. Perret, could you provide some insight into why those aspects of the strategy have not been started?
Well, the insight would be just the volume of work on our plate and sort of priorities. Certainly, it's not an indication of their importance. And as the reorganizing of the department lagged behind the consolidation of the health authorities, and there's been some work in staffing it up and orienting it and getting a new system in play and playing a role that hadn't been played in the past. So it is a lag time issue.
Okay, thank you. Last session, the NDP Caucus tabled legislation that would require the health authority to report publicly on several service delivery indicators. One of those was the number of days between an individual's first choice and partnership approach appointment and their admission into a community-based mental health program. I wonder if someone could explain first of all, what a patient can expect at a choice and partnership approach appointment.
Ms. Peach?
Sure. Happy to answer that question, and it's a great opportunity to provide some clarity. So as we'd indicated, the wait times reporting on a go forward, so starting in this fiscal year, the first quarter, we'll be able to report on wait times to urgent appointment, wait time to regular appointment, wait time from referral to the first appointment, the choice appointment, and then wait time from the first appointment to the second appointment, which is the partnership appointment. So completely agree that will be, and I will explain that to you, the difference between them. So the most simplified way of explaining it, the choice appointment is really an opportunity for the individual to sit with the clinician and identify goals that they would hope to achieve through treatment, and then through a matching process be able to match up with the best clinician to be able to provide that support to them to achieve their goals. And so the partnership appointment is really the follow-up to that, which is an opportunity then to start on the work together to achieve the goals that have been established in the choice appointment.
And so currently, do we have access to wait times between, first presenting in some fashion to the system and that partnership appointment? I think what matters to people is if you are in some sort of mental anguish, that mental anguish is relieved, and I am picturing that really happens at that partnership appointment.
Yes, so we recognize that as well, which is why we've also agreed and made the suggestion that we need to capture both points in the system. What we were identifying is individuals may get into that first appointment quickly and then have a significant wait time to get to the second appointment. So we want to make sure that we capture both so that we have a full understanding of the wait time issue and are able to focus our attention and efforts around that. So is it that people are waiting a long time to get into the first appointment, or is it that they're waiting a long time to get to the second? So right now the wait times just report the time from referral to that first appointment.
And when can we expect to see a more meaningful reporting on wait times?
So we'll be able to report on that for the first quarter of this year, and we'll see those reports in August, as Sam had indicated.
Okay. Just drawing on the work in the milestones report, and the base of the pyramid, the fattest cohort of folks seeking some assistance who are less urgent. I don't know exactly who would be best to respond to this, but I'm struck that both the fact that they are presenting to the system in many cases may be tied to living in poverty, and also in many cases people living in poverty do not have access to the other services that people often seek out through employment assistance programs or through private insurance. Would somebody just take that on in terms of like the significant determining impact of living on low incomes?
Ms. Hodder?
I can take that. So what you are referring to within the milestones document is essentially what we're calling a tiered framework or a tiered level of care, with that bottom base is actually representative of the general population. And so our efforts will be around for that, to look at that would be around strategic approaches to healthy public policy, to look at the social determinants of health, keeping people well. So those folks in the bottom component of the pyramid wouldn't be seeking service provision from our mental health and addictions system.
So so that base of the pyramid actually represents the entire population?
The base of the pyramid is what we're referring to as tier 1 would be the largest portion of the population. Those folks are generally not help seeking and could benefit from that strategic approach to reduce their harms, reduce the injuries associated with substance use, promoting positive mental health and well-being.
Okay, so, but when we were talking earlier about the current wait times reporting and how that, you know, includes folks who have been triaged, there would be a portion of people in that group who are experiencing distress that is, I mean, I'm thinking back to a constituent who said, that, you know, she actually got in to see an appointment and the clinician she spoke with, you know, sort of identified that a significant contributing factor is the fact that she's living in poverty and that she's in constant financial stress. So she's not suffering acute, she's not urgent, she's got life circumstances which are bad for her mental health.
Yeah. So that would be a few steps up in terms, even that person that you're speaking of would be a few steps up in the actual pyramid. It might be helpful if we had a conversation about how that pyramid's actually structured and how we see that in terms of step care. I'm not sure if that would be helpful or not.
I think that would be fine. Am I out of time?
Yes, you are. Yes, you are.
I was like, I knew I was heading for 9:57, so.
How good of you.
So maybe one of my Liberal colleagues will allow you to do that.
We'll go to Ms. Lonis-Croft.
Cutting in on my time. Thank you for being here, and I'm learning a lot of information, and there's good work going on, I can tell, and there's some very bright people working to help our mental health system, and I'm glad to hear that and to see that. So you and your colleagues that work with you and do a lot of the work, you are, I know it was a system that sort of didn't exist before, and you're trying to build it. So kudos to all of you who are, you know, bringing this together. It doesn't happen overnight. I realize that. It's going to take a lot of time. I will ask you to do the pyramid after I ask an initial question, because, you know, there was a lot of questioning about access and wait times. What do we do while we're waiting? I think that's an important message to get out to people while we're waiting. I strongly believe in preventative health, mental health. You know, there's things you can do. So there must be resources in our communities now that exist. You know, I know there's Schools Plus and other programs. I refer also to Pat McGraw's Healthy Families Institute. So what can we do while we're waiting? And some of the time periods seem really long. So while you're waiting, surely there are community-based or virtual, because I think that's where we're going. Our kids are accessing more and more online services, and so are parents. So while we are waiting, what can we do? And maybe the pyramid comes in play in that. So whoever wants to do that, or maybe there's several people who want to contribute to that. What do we do while we're waiting?
Okay, Ms. Knox.
Okay. I'm going to start, and Ms. Hodder will talk about what we're doing. It's a very important point you're making, because all Nova Scotians need to hear that. While we understand the needs of Nova Scotians, we have to step in with the people who need help now. And so it's a two-pronged process, planning to serve better now and into the future, and caring for the people who present now. So I'll ask Ms. Hodder to talk about how we do that.
Ms. Hodder.
Thanks. So there has been resource investment within the system that Nova Scotia Health Authority, along with the IWK, has begun to implement to answer that very question, models that are grounded in evidence and that we know that are effective. So one of the examples would be our Caper-based outreach team, which is really looking at early intervention and outreach services for youth at risk. The overall model started in Cape Breton many years ago, probably about 7 years ago, and was evaluated. It was funded actually originally through Health Canada under the Drug Treatment Funding Initiative. And the robust evaluation was shared with Department of Health and Wellness, and they maintained the funding and sustainability of that program. When Dr. Couture did the visits and psych consultations in Cape Breton, part of the recommendation was about further enhancing and expanding that model of care, saw it as a value as well as the evaluation. So what we're doing and what the provincial approach to mental health and addictions allows us to do is scale and spread. And so we've enhanced the Caper-based outreach services in Cape Breton in response to that recommendation. So actually hired people to be working in communities and schools for youth at risk. But we've also then linked up with the other areas across the province to be able to add additional resources and model that care. So within the Western Zone and within the Northern Zone, we are hiring, in the process of hiring youth outreach workers to be able to implement that framework and model of care to expand reach and access for youth at risk. So that would be one example. The other commitment that I would like to talk about in terms of actually resources is around our community mental health and addiction clinics, which gets a piece at that will target and help with those wait times that we spoke about earlier, but we are adding additional mental health and addictions clinicians now to our complement. It started within Cape Breton because we knew that because it was driven by need, and that's the whole lens that we're driving everything by, is not just making decisions based on geographic location or history, but actually looking at the needs within the communities and then targeting those resources to match those needs. So 5 additional clinicians have been targeted for Cape Breton from the last budget, and then this upcoming year we'll be hiring an additional 10 mental health and addictions clinicians across the province for resources investments. The other piece is in relation to, and I think it speaks to that piece that we were talking about before around urgent care. And we've looked at our crisis teams across the province and recognized that in order to better meet our benchmarks that we're setting in terms of our bands, because we're utilizing all of our key performance indicators to guide our resource investments as well, is that we've added additional complement to our crisis teams that'll be armed from our crisis teams to be offering urgent care clinics within each of the areas. So 13 FTEs have been targeted for that, and I think we're over half staffed now to be meeting that urgent level of care needs. So there is, at the same time as that we're planning and we're projecting what the needs are, when needs are identified, we're having those conversations. They're deliberate and they're intentional to meet our commitments to the Nova Scotia population and investing those resources where the needs are presenting. So those are just some examples of what actions are being done to date while we're waiting to really facilitate that system transformation effort that we're talking about.
So following that, how is this being communicated to people who are accessing mental health and are on the wait list? How are parents being communicated to on where to go for these resources?
I think that's a really, really great question because when we looked at our system and the access points, you know, the very where do I call to get help when I need it? I started off when the Health Authority started in Northern Zone, and we did a review over access points, and there was over 36 different ways to enter into the system, which is very complex.
Navigation.
Navigation. And we were having conversations about hiring and additional resources to navigate when we should be just making the system easier for people to navigate. And that's where our central intake or access navigation is what we're calling it now. It comes into play, and that's a collaborative effort with the IWK as well. So we're adding additional resource investments and have a project team scoped out to create one number where Nova Scotians can call to get help. So it's, I need help, and we'll help to do the sifting and sorting and help to identify if there's something that we have within our system of service provision and care that can offer that best meets their needs and supports their recovery, or is there, and thinking about that step care model, or is there something in community that would better meet their needs or match their needs? Is it that a family doctor or within primary care that could help support or care for their needs, or is it something from the formal mental health and addiction system or community organizations? So getting that central access and navigation initiative up, which our target is next year to have that up in place, I really think will help facilitate seamless delivery of care and services for people within our system, as well as helping to facilitate access to other community-based services and supports for Nova Scotians across the lifespan.
So as an MLA, and I'm from rural Nova Scotia, so we can't always access IWK services like someone in HRM. I must say our mental health services have been fairly good, that I'm quite, and I know people don't know to say, put me on the cancellation list, because people get bumped up very quickly on the cancellation list. So as an MLA, I get parents calling me who just don't know how to help their child. So I think, we need to help parents, to empower parents. So how do we go about doing that? Empowering parents, because they're probably the first person a child talks to. And parents themselves are stressed. They have so many stresses themselves with work and, raising families, and some are, having financial issues as well. So we need, and that's part of prevention too, I see. Healthy bodies, we're reading more and more about less screen time for children, but then our education is encouraging screen time for, using more tablets and iPads in the schools. So where are we going to get that balance? I know children should be outside more, getting fresh air, good nutritious food, and then you have financial issues that sometimes prevent that. Would someone like to speak on that?
Ms. Perret.
So it's an important question, and what I would say is that it's being addressed from a number of different streams. So as Ms. Hodder said, you've heard some of the work that's going into building that core capacity in community clinics and to looking at how we systemize triage and get those most in need. As well, we've got an initiative, and this has been guided by both the Minister's Advisory Committee and Dr. Kuchler himself, on building out our youth wellness centers so that there is good information for youth and that we're connecting on the health prevention promotion basis. That needs to, as Dr. Kuchler's directed, be linked and connected into what we're doing in Schools Plus, which is also being built out. And the mental health clinicians that support Schools Plus are connected to the 31 community-based clinics that we have throughout the province and have access to additional resources. And that's a very good connection for families and youth to make. We've mentioned the Strongest Families Institute. And I was talking to someone yesterday, a family with their child who had run through that program, who had nothing but good to say about how helpful it is in certain respects. And another stream that we're early days that will be growing is through My Health Nova Scotia, because what you want to have, and to your reference to people accessing tools on site and supports on site, Dr. Google, so to speak, we need to have a source of trusted health information, a source that parents, individuals can go to find mental health resources and other resources, and our platform for building that up will be through My Health Nova Scotia as well. So those are some of the initiatives that we're either growing and expanding or that are in play.
Sure, Ms. Hodder.
Ms. Hodder.
I'd just like to add to one of the initiatives that we had committed to and started as a demonstration project, and you had mentioned it, was in relation to virtual care. And I think that's a really exciting opportunity that we have for Nova Scotians, particularly those living in small towns and rural communities, in terms of enhancing or expanding our reach. So last fall, we did do a demonstration project in relation to virtual care utilizing a Medio platform. And we had 10 clinicians across the province participate, we had, I believe it was just over 150 patients be identified as being appropriate to participate within that model of care. I believe there was 63 people who accepted an appointment, and then 49 actually completed the virtual care appointment. Most of those folks were from small towns or rural communities. And so I think going forward and thinking about innovative strategies, we need to be talking about virtual care. How does that enhance our reach? How does that help facilitate ease of access for a mom who's not able to get childcare in place for her to attend a clinical appointment? How do we help someone who doesn't have access to public transportation in a small town or rural community, or that the bus schedule or transportation is just too long? It's a day's event. And so thinking about innovative and creative strategies to do that and to get our services out there, I think is the way that we need to be moving forward. That's not to say that that's the only option, but it needs to be another option available for folks. We had very good satisfaction rates as well. So we looked at implementing an evaluation, which was talked about and commented earlier. All of our initiatives that we're implementing have that process as well as outcome evaluation component built into them, because we want to know going forward, is it effective? Should we continue to spend our resources in this way? And so we've had 94% of folks who had participated say that they would utilize that service again, and 87% said that they were overall satisfied with the level of care that they received during that virtual care visit. The most common reason or issue was of why they may not have been as satisfied was some technical glitches. So that's an opportunity for us to go back and look about how do we educate folks and how do we ease those technical difficulties so that we can make that experience 100% positive for folks.
Oh, great. So can we, who's most familiar with Schools Plus? Right? Okay. When they first rolled out Schools Plus, it mostly was involved the justice system and slowly has come about. It's growing, and it's growing in more areas and more schools. So can you speak about accessing it? Because I know sometimes it was a referral system within the school system that the guidance counselor or the principal referred students to Schools Plus. So, you know, some people weren't aware of how it worked. So can you give us some details on how School Plus works?
Ms. Peach.
to do that. Also, perhaps to start with a bit of a clarification that's sometimes not fully understood. So the mental health clinicians that are part of the Schools Plus program are part of the mental health and addictions program. They're mental health clinicians functioning in the school setting as part of a Schools Plus team. And as we mentioned earlier, one of the things that we quickly discovered early in the days of the Nova Scotia Health Authority was the extent to which some of the services, even though they were provincially implemented or initiated as a provincial program, the extent to which they varied. And Schools Plus was one of those examples. How those clinicians were working was quite variable across the province. And so we've undertaken work together with our partners at the Department of Education, working with the IWK and the Nova Scotia Health Authority to establish some clarity around the roles and responsibilities of those mental health clinicians and how they function in the school setting and how they function as part of the Schools Plus team. And we're certainly seeing some of the success coming from that clarity. The other thing, we've seen some significant investment in Schools Plus mental health clinicians over the last number of years. And just to paint a bit of a picture around the visits provincially, so between 2014 and now in 2017, we've seen a 55% increase in the total visits associated with Schools Plus. So we're certainly able to reach children where they are. And as Ms. Hodder had mentioned, through the Caper-based expansion initiative, we're also able to reach youth who aren't in schools. And so it really is that combination of the two initiatives to build resiliency, to have early identification of individuals when they do require some more intensive support, and to be able to pick those individuals up early and refer them to other parts of the system when we need to.
Great. Do we have time to talk the triangle?
You have 1 minute remaining.
Well, can we do some work on the triangle?
Ms. Hodder?
Try to do it in a minute. Okay, so basically what the pyramid does is it's what we're calling step care. And so it's the overall goal is to operationalize service delivery to ensure that there's access and transitions at each of those steps, and an overall engagement approach to patients and families when they need us. So tier 1 is at the base of the pyramid, and those folks, they likely don't need mental health and addictions related care from the formal system. They're folks that are in the population that benefit from overall health, wellness, keeping people healthier, looking at healthy public policy, whether that's reducing alcohol-related harms, cannabis policy, all of those sorts of things. Tier 2 is really around the fundamental role of primary care and other community-based organizations. And so people may be experiencing mild...
I'm sorry, time has expired for that round of questions. We'll move back to Mr. Houston of the PC Caucus, this time for 11 minutes.
Thank you, Mr. Chair. I already shared my 30 seconds before. My colleague was talking about families and interactions with the system, and I do want to acknowledge the work of the IWK with the Garron Centre and stuff. Some terrific work that you notice you're not getting many questions. There's a reason for that, so keep up the good work there. We're talking a lot about wait times and understanding wait times, and that's good. I'm happy that that's being done. It's 4 years since the Health Authority started, so it's good that information is getting assembled at this stage. But the question then becomes, so what do we do going forward? Like once we have the information, how do we get the services to the people? That's really what the question is now. What's the strategy? And what would the Health Authority do if 25 psychiatrists drop down right now? Would you have a plan as to, would you send them back? Is it too many? Is it not enough? How many psychiatrists do you need to add to the system, and do you know what to do with them if you have them?
Ms. Knox.
Thank you. I just want to say it's 3 years, not 4. We do expect to see a very big difference in additional 12 months of this very focused activity. And we are, in terms of recruitment of psychiatrists, that's a major challenge for Nova Scotia and for across the country. And so our goal is to be very focused and take as many as we can. And we can, Lindsay Peach can tell you the numbers that we are looking for.
Okay, how many psychiatrists do you need to add to the system?
So
Ms. Peach?
Oh, sorry. Thank you. So current vacancies that we're recruiting for is 22.5. We do recognize we do have significant challenges with psychiatry, and a number of things have happened over the last year that have created some situations with vacancies that were unanticipated. We've also, I would say, as context to that, two pieces of work that we're doing. We are doing work with psychiatrists to look at their role within the mental health and addictions team to really make sure that we are maximizing that resource within the team. So that's a piece of work that we're doing together with them. The other thing that we've undertaken, particularly identifying the challenges with psychiatry vacancies both in Northern Zone and in Eastern Zone, particularly in Cape Breton of Eastern Zone. We've done work with Central Zone Psychiatry and have just recently, just started last week, a telepsychiatry option, so that we do have psychiatrists in Central Zone that are providing that support through technology to support clients and individuals living in both Eastern Zone and Northern Zone.
Thank you. 22.5, is that just to kind of get to the, let's call it the base level? Like what's the real level that we could provide really good service to Nova Scotians?
That would be the number identified in the physician resource plan. I think the other
what is that number?
The total number is 132.1.
Psychiatrists?
Mm-hmm.
So
for the whole province.
That's what we should have, and we have
22.5 vacancies.
Oh, so the 22.5, those are actual positions that people left, or are they? Okay, so those are positions that people left. So that assumes that we had enough. But what I'm asking is, did we have enough? And so in other words, if you have one psychiatrist and they leave, you have zero. Yeah. But maybe you needed two to begin with, but you only had one. So I'm trying to get to what's the real. Yeah.
So the number identified in the physician resource plan is 132.1. But as I mentioned earlier, the context around the role of psychiatry is work that we're doing. So what is the right number is planning work that we're undertaking with psychiatry. I think the other.
So you don't know the right number then?
We know the number identified in the physician resource plan.
But are you comfortable that's the right number?
I think that's the number that was identified based on that planning. But again, we're doing work with psychiatry around the model of care and their role within it.
So what year was the physician resource plan updated that came up with the number of 132.1?
The department can answer, yeah.
Ms. Perret.
Thank you. The physician resource plan is updated every 2 years. You'll see a new update coming out shortly. We have Dr. Wilson working on that. He's traveled the province extensively, meeting with all the specialty practice groups. And so he's also looking at both the numbers that are projected, but Ms. Peach made an important point, but also the clinical setting and the clinical requirements. Because, and this is a Canada Health Act issue, back in the day, you could access psychiatry resources for free, not so much in the community for psychosocial. Like part of the transition that's taking place in the country is appropriate care and getting the right care. And it's an important point because we don't want to have healthcare profession shortages. We want to use healthcare professions to full scopes.
Okay. Dr. Wilson is updating the physician resource plan.
Correct.
And when do you expect like a draft or something of the physician resource plan?
So it's near completion.
Have you seen a draft?
I have not seen the draft
yet. Has anybody with us today seen a draft? Okay, so near completion, what do you expect within the month, or when would you expect to receive that report?
So I'm not sure if it's within a month. What Dr. Wilson's doing right now, and it wouldn't be unusual that people sitting at this table haven't seen the draft because he's working with the actual clinicians and the department heads in the field and reviewing the results with them and making modifications. But they have the work done and they are fine-tuning it and doing that double check.
So the world changes, the environment has changed over the last 2 years. So 2 years ago, the indication was that we needed 132.1 psychiatrists in Nova Scotia. Would you expect that today, knowing what we know, that number would be higher, or would that number would be lower? Do you have any expectation of what that would be?
So no, that's why Dr. Wilson's doing the work he's doing. That's why it's not just a projection, but it's also the work he's doing with department heads to determine what the right clinical practice model is. And it's also why we're making an investment in community psychology and social work, because this is based on the social determinants of health, and we want people to get appropriate care. We don't want to use always the most expensive and scarce resource when it's not necessary, when it's not appropriate. So this is part of the Choosing Wisely initiative, if you like.
So you don't have any sense as to whether, if 132 were required 2 years ago, you don't have any sense of whether there'd be more or less today?
I don't know that number today. No.
You don't have any gut feel as to higher or lower?
No, today I don't.
Okay. And Ms. Knox, do you?
Ms. Knox?
No, I don't. But I would like to reiterate what my colleagues are talking about. It's really about how the whole team works together, and so revising one resource plan is really important. So, but it's a plan that's the physician resource to this mental health and addictions team, and then there are all the other practitioners that we need to take into account. So that's our work as we go forward, and I'm very encouraged that we're updating our work and really making sure that we're understanding what differences we're creating. It's a really important question you're asking, because we have to be open to using the most important resource and making sure we have them then.
Yeah, it is. Actually, what I'm trying to get to is how in touch, trying to get a sense of how in touch the people running healthcare in the province are with the needs of the people. That's really what I'm asking. How in touch are the people that are responsible for spending $4.5 billion of money to deliver healthcare? How in touch are they? And I'm asking, what is your sense that, we know cannabis is coming. That's going to have an impact on mental health in the province. We know the stigma is reducing. More people are seeking out services. We know these things are happening. We know there's a greater awareness of autism and things. We know a lot. My sense is 132 is probably going to be higher. That's what my sense is. But I'm asking, what if you have a sense of that, and if you do, you're not willing to share it, I guess, is what I take from that.
Ms. Knox?
I think these are all really good questions that you're asking, and it's creating the opportunity for all of us together to really constantly be reviewing what are the needs of the population and be open to new models as we go forward. So in our organization, we have 191 physician leaders, so they'd be all the folks that Dr. Wilson would be talking about. So we are encouraging and supporting them to do their work.
You must talk to them too, right?
I do. But I don't, we will wait till they have their report. It will be all part of our work. In our planning for mental health and addictions, this is multidisciplinary team that works together across the three organizations. So it is really important that we are making ourselves available of all of the information, and then the team members can debate what does that mean for them, and how do they contribute the very best they can be. We have a lot of effort in
just in the interest of time, if I may, Mr. Chair, I mean, go back to where we started. You made a statement about working with the funders. The deputy talked about a much stronger publicly funded system. So then we need to be honest about the needs, right? So now we understand the wait times a little better. We're doing a 2-year update of the physician resource requirements. We just passed a budget. So the budget's passed. There's going to be, my expectation is 132 probably isn't going to be enough in today's terms. So in kind of assessing the budget for the year, you would have had to ask for more money if you thought it wasn't enough. So otherwise, we're always going to be behind the 8 ball. We're going to get a report. It's going to say
order time has expired. We'll move to the NDP Caucus and the Honourable Dave Wilson.
Thank you, Mr. Chair. I want to return to an area that is concerning for me, and I think of Nova Scotians, and that's around the federal funding and an agreement or not an agreement being signed with the province of Nova Scotia. I don't know what happened in December of 2016. There was an announcement that there was an agreement, but there is no agreement. I guess it was just a friendly, mutual pat on the back between the federal government and the provincial government, and that we're supposed to trust both levels of government to act in the best needs of Nova Scotians. The federal government plays an important role in the province achieving providing services in healthcare with the federal transfers. And for decades, we had the Health Accord. And of course, now we're here today hearing that there is no agreement signed, that Nova Scotians can hold the current provincial and federal government to account. Is there any timeline on when that agreement would be signed between the provincial Nova Scotia government and the federal government?
Ms. Perret?
So thank you for the question, because I do want to clarify a point. So there is an agreement that was reached on the overall funding amounts for the 10-year period. So that's not in question. What we're talking about is the bilateral negotiations that are underway as to an agreement as to how the money is spent, both in two categories, care in the community and mental health and addictions. And there is in the accord that was reached certain criteria that the federal government had down, some of it which is a priority on children and youth and that type of approach. Also looking at innovations in how we deliver care. So you've heard a bit of the discussion on virtual care. And so that's how we're looking at using that space. So where we are now, the discussions with the federal government, and they're constructive discussions because everyone wants this to work and to succeed. We're also having discussions with the Canadian Institute of Health Information, as is every other province and territory, because that's how results and outcomes are going to be reported. So I can hear the minister's. No, I can hear the minister's voice because I'm about to say the word soon, and he has an issue with the word soon. But those discussions, negotiations are well underway, and I expect that we'll have information, if not by late spring, by early summer.
Late spring, early summer, because the emphasis is that this needs to be ratified, and I think it's important for Nova Scotians to have something. They should know exactly what kind of agreement our province is entering with the federal government, and it's really about accountability. I think you mentioned election cycles are disruptive. We're a year and a half away from the next federal election. Who knows what will happen? Maybe Justin Trudeau will take enough selfies that he'll get re-elected and everything will be fine. But I don't trust that. And Nova Scotians, I think, don't trust that. And there needs to be the ability to hold government to account and not just trust me. I'm very concerned that it's taking this long to get to that point. And I know that's not all on your plate and everybody's here, but I think those who make the announcements are the ones that may be gone. Most of you will still be here to continue on, and I know that elections are disruptive. I mean, 13 election, we amalgamated district health authorities. It put a lot of things on hold until we could figure that out. And we're just here, finally, 4 years later, hearing about some of the positive things about the work that's being done. And that's why I have concern that it's taking longer than anticipated. When we looked at the mental health budget, we heard that it was about $287 million. Being spent on mental health and addiction services. How much of that funding comes directly from the federal government? Are you able to give us a number? And I know we try to go through this in estimates, but there's a lot of numbers, there's a lot of components to it. But are you able to provide us with that $287 million, approximately how much does come from the federal government? And there may be strings attached to it, there may not be, but are you able to provide any detail on that? Ms. Perret?
So the Canada Health transfer portion is really a question that's best addressed by the Department of Finance because it's a revenue source. within this budget, and referring just to your comments earlier, I do want to assure you that in the work we're doing with the federal government, there are early indications that we're on the same page, and so it's not, there's not going to be a lag. We're going to hit the ground running when the bilateral is signed. So I don't have it, and I don't have a breakout of the 287 that would come from federal funding.
Just quickly going back to that, as I turn my page over, I'm just putting notes down. Is there still opportunities for the Premier, for example, to live up to his commitment to Nova Scotians to recognize our demographic, the age of our province? He had indicated that he would not sign anything unless the federal government recognized that Nova Scotia has one of the most aging populations, and that puts a pressure on delivering services in the province. So is there still an ability to maybe have the federal government recognize in a final agreement that our age of our province is going to have it's going to put pressure on our ability to provide services as we go forward, especially for a 10-year deal?
So two-sided coin. My assurance to you that there is an agreement on the funding over the 10 years is in place. So the other side of the coin is no, that agreement's not going to be opened up for a different type of funding arrangement. I will tell you that we interact with the federal government not only just in the traditional FPT space, but through other mechanisms such as ACOA and the like, and we work as an Atlantic region often to look at opportunities, and the federal government is quite responsive in wanting to work with us and to recognize that this is an aging demographic in this area of the world, and I don't think doors are closed entirely.
Okay, thank you for that. Just go back quickly. I know Ms. Hodder mentioned around the new kind of band system for wait times for mental health and the criteria, and it's being rolled out throughout the districts. I know my colleague mentioned, read off some of the wait times around the province. You indicated that certain areas were following kind of the new criteria. When do you expect all regions, all facilities would be implementing this new criteria when we're talking about wait times?
Ms. Hodder.
Yeah, so our commitment is to have our access and navigation project implemented within this year. So it would be in April of next year that we would be live across the province. That doesn't necessarily mean that there isn't improvements at the local level and learning shared across the province, and that doesn't necessarily mean either that the model that is implemented in Cape Breton and Northern isn't going to have significant improvements as well, based on the work and the research and the evidence that's being implemented there, because we are looking to have a full provincial approach to access and navigation. Some of the components that we implemented was a recognition that in those areas there was a need to take immediate action and address that. And so as we're uncovering things within the new model of care, we're implementing and adding resources as the needs are coming up. But our plan is to have our access and navigation project for Nova Scotians implemented next year.
Okay, thank you for that. And I know often the measure of success for government is those numbers, is the wait times, and I know it's complicated, but ultimately the public, that's what they see. You know, we have websites, we hear numbers. Often that's where we go to explain to Nova Scotians if things are going well or if they're not going well in certain regions. With the change in criteria, did you remove people off the list that were on the list maybe for some time, so the criteria changed enough where they were removed from that list? And the reason I asked that, there had been a change to the list, wait list for long-term care, for example, and it wasn't the number, and the government uses those numbers often, but when you dive into the numbers, you realize, well, the criteria changed, so people were taken off because they don't meet the criteria. But yet the government tried to use that as a success, even though not no additional money had been put in the budget to add long-term care facility or beds in the province. So was there a criteria change that would just take people off that list? Hopefully I'm kind of clear on how, why I'm asking the question.
I'm not able to comment on the piece around what government did or didn't do in relation to that, so I can't comment on that. What I can comment on, because I was involved specifically within the system improvements within Cape Breton, is that every single referral that came in that was waiting had some contact by our service provision. The referral was reviewed and an attempt to reach out and actually speak to that individual who was the referral was made. So at some times, I can say that people weren't able to be reached, but that doesn't necessarily mean that we stopped there, because we also sent out letters that said to folks that we've made an attempt to reach you, you weren't available. If you need us, here's how you can get back in touch with us. So I can speak to that specific experience within the Cape Breton area, that there wasn't...
Order. I'm sorry, the time has expired. We'll move to the Liberal Caucus. Mr. McKay.
Thank you very much, Mr. Chair. And thank you very much for all the good news you've been sharing. There's, there's been some tough questions, which we appreciate and have to ask, but out of those tough questions, we're hearing some really good news about things here in Nova Scotia. I'd like to perhaps go back to, I think, the original question that was posed, and I think Ms. Knox addressed it, that we don't always follow the crowd. That we have situations, opportunities and challenges in Nova Scotia that are not necessarily met by just doing the same thing that everybody else is doing. We've got highly qualified professional healthcare workers in here in Nova Scotia. We've got top-notch medical research facilities here in Nova Scotia. And while we obviously, from what I've heard today, we take best practices from elsewhere, but we also develop our own solutions, unique solutions to approaching healthcare. And, that can be for doctor recruitment, but it also, I think, applies here in mental health. And I guess I'd like to address the question perhaps to the deputy of how are we doing, say, relative in the overall Canadian situation relative to other provinces?
Ms. Perret.
Thank you. I think generally speaking, all provinces and territories, and it's a reflection of the questions about the federal bilateral agreements, are focused on building a mental health and addiction system that really hasn't been a system per se. And as I said, I used the analogy to some of the discussions we're having on pharmacare, that it's not been part of universal health care in the country. And so we're starting a bit behind the game and building it. I think in that context, I've worked in 3 provinces and I've spent some time at the federal provincial table. Nova Scotia is well situated to respond to this challenge and to do some really good work. Nova Scotia has invested in foundational elements that are in place. We have to grow them. We need to integrate, connect them. But just the system of 31 community health clinics throughout the province, the system of the schools plus hubs, and how we're growing youth health centres, in many respects, to have this foundation would be the envy of the other provinces.
Good, thank you. I'm going to go a little bit outside the box on my next one. It's regarding, I think, the holistic approach that Nova Scotia government is taking to mental health in so many aspects and through different departments. And I will ask my colleagues' indulgence a little bit on this one, because it's something that my own family was impacted upon, and one of my nephews went through the mental health courts system, and initially I think there was some high concerns in our family about that, but the outcome was highly successful. We could not have been happier. Since there's nobody here from the Department of Justice, I'm just wondering, perhaps the Deputy again, any comments on mental health courts and where they may be going from your perspective, understanding it's not your department?
No, and I won't do the question justice, so I apologize on that point, but I will assure you that on the social deputies and social ministers front, that there's a real concerted effort to work across departments and to work in an integrated fashion, and we consider these challenges to be government challenges that we all rise to address, and we don't work in silos.
Good. Well, a holistic approach, and I think intergovernmental is working very well. I think I'll address my next question to Ms. Vine, if I may. We've heard quite a bit from the Health Authority and the department, and like my colleague from Lunenburg, I represent a primarily rural riding, and I know the challenges faced in a riding such as my colleague from Halifax Atlantic are quite different than what we have rural. We speak of outreach, and one of the things I believe I heard was that the lessons learned in maybe some of the other zones, perhaps within HRM, will be expanded to other parts of the province, and in my case that would, I guess, be in the western part of the province. And I'm just wondering if you could expand a little bit upon the IWK's participation in outreach to other parts of the province.
Certainly, I can make a few opening remarks and then I'll turn it over to my colleagues. But definitely, I think as we've really worked to transform our services at the IWK, recognizing some of the specialty services that we are able to offer are not available within all community mental health clinics across the province. We take that role very seriously in terms of working very closely with our colleagues at Nova Scotia Health Authority in all aspects. So as we are developing a particular evidence-based program or approach, while we're training our own workforce, we're working on training the workforce of our colleagues within NSHA so that when they're working across systems, which we do all the time, they're speaking the same language, using the same evidence-based approaches. So in general, that's the way it would go. And I can pass it to Dr. Bagnell, who can talk about some of the consultation work that psychiatrists from the IWK regularly provide across the province.
Please do.
Yeah, that's a great question. Thank you very much. So, I mean, I think we've had a really great opportunity because IWK is partnering with NSHA and we're together at the provincial table forming a strategy and moving it forward, that we get to know each other really well. So we've created a lot of great networks, and we have a child psychiatry network now in the province. We're not a big group, but we're a very cohesive group, so we know who to call. And one of the things that's clear is we don't have child psychiatry coverage throughout the province right now, and I'm sure people have heard about that. So how do we support those areas? So we have a telephone consultation service. We developed that a couple of years ago. It wasn't as well used as we would have liked, so we promoted it more, and we've been having a lot more use. So physicians will call in and can get a telephone call consult with a psychiatrist within a couple of days. We have set times, it's booked, and then we call that physician. So that's been really helpful for just that immediate decision. What do I do next? What would you consider? Should I be referring in? So just getting that started so that someone's not waiting in terms of the family physician or pediatrician not knowing what to do next. And then the other is consultations directly to psychiatrists. We call them physician consults. So a physician can consult us from anywhere in the province with a question. It's usually a one-time consult unless there's a serious mental illness that we feel needs to come into the IWK for intensive services. But it really has been helpful because people don't wait as long. We can actually recommend evidence-based treatments that could be available in the province to help as well and connect people. And then we can remain as a resource to that physician as they're moving through the treatment. So those two things in psychiatry have been really helpful. And so we're hopeful that that will continue to build and grow.
Good, and I think that speaks to the fact that we are addressing the now and the future in mental health care across the province. And speaking of how the approach is to mental health care on a provincial basis, I'm wondering, Ms. Knox, if you could comment to the how the creation of the Health Authority has impacted our provincial approach to mental health care.
Ms. Knox.
Thank you for the question. So the Health Authority's mandate is to provide health services to all Nova Scotians in concert with our colleagues at the IWK for the services they provide. And so the creation of one organization, as Ms. Hodder gave an example of, in one zone, there were 40 different ways to access services. Multiply that by 4 and we're in the hundreds. And so this gives us an opportunity. I know that doesn't sound 4 by 40 isn't a, but there were many, many, many multiples of that around the province. So planning together, bringing this mental health and addictions team in Nova Scotia Health Authority brings together the leaders from all across the province. They plan based on who the people they're serving, and the implementation is local. So I really want to, we bring the best of our information, the best of our resources together, and then the implementation of all of that benefit is at the local level in the context of who people are living in their family, in their community. And so in 3 short years, I would say there were 3 long years of work, we're starting to see the benefit of that and really being able to see how you can maximize expertise, not have to duplicate it, quickly move it to where it needs to be, and replicate best practices. And the other thing I would like to say, with a philosophy that as we came together in using all the work that went before us, we made the commitment that we have to stand on the good foundation of all the work that went before us, and then constantly use the best information in the world that is available to us now. And we're very pleased with the level of practitioners that we have in this province. We should be celebrating them. We have the expertise. It is how we put people together in relationships and really stay very focused on who the people are. So thank you for the opportunity for me to share that, because I have been in this system as a CEO for more than 13 years, and this is very, very different in terms of what we're able to do in saying that all Nova Scotians need to be treated with the same rights, and sometimes our strategies will have to be very different because of where they live or what their circumstances are, but the treatment and the care that they get has to be to their needs.
Order. Time for questions has expired. We do have some committee business, so we don't have a lot of time for closing comments, but I would like to offer maybe just a quick 60 seconds to each organization that's with us today, starting with Ms. Perret.
Thank you, Mr. Chair, and thank you to the committee. I think it's an important discussion. I think that the people of Nova Scotia know that we're at work and we want to improve the system, and also that we want to remove the stigma in this area and make it a conversation that we have throughout communities. So I thank you for this time today.
Ms. Knox.
I just want to say thank you for your interest. This is very important work. We must not take our focus away from supporting Nova Scotians to be the healthiest and the best they can be. So thank you for your interest.
And Ms. Vine.
Again, I would like to thank all of you for the opportunity to provide information to you, and I really want to echo the comments from Ms. Knox about how fortunate we are to have the incredible workforce that we have in Nova Scotia, and how important it is that they hear from Nova Scotians about the great work they're doing. It's challenging work, and they deserve our support and respect. So thank you very much.
Thank you to all of our witnesses for being with us today. We appreciate your presence and your ability to answer questions for us. Thank you. We have committee business, starting with correspondence. We had correspondence from Department of Health and Wellness proposing an additional witness for the May 9th meeting. The question before the committee is do we wish to approve the additional witness? All those in favor, please signify by saying aye. Those opposed? So our clerk will make note of that. The other piece of correspondence is from the Department of Environment, and it has to do with information requested from our March 28th meeting. Information has been provided, but the answer to one of the questions, it was suggested that the question was better asked of the Department of Transportation Infrastructure Renewal. Does the committee wish to pursue that answer with the Department of Transportation? All those in favor, please signify by saying aye. Those opposed? Thank you. So our clerk will make note of that. We have a record of decision from our subcommittee on future topics for our meetings. You have before you a list of topics. There are 7 topics plus one being the Office of the Auditor General, who has a report that he's delivering on May 30th. As I recall, we've already approved that for May 30th, but there are 7 other topics there, and we need your approval on those. Mr. Houston?
Thank you, Mr. Chair. I make a motion that the committee approve these topics.
Mr. Gordon Wilson.
Yes, so we do have 7 there. I'd like to note that there are 3 that we do have for the Progressive Conservatives in light of one of them that we thought would be one that would be dealt with better through the Auditor General's office, which I do believe everybody knows has embarked on working on that. So I think it'd be a little bit preemptive of us right now at this point in time to approve that.
Can you identify the specific topic?
That would be internal services supplier contracts related to the FOIPOP breach.
Okay, so are you recommending that, so the motion before the committee is to approve all 7 topics. Perhaps we will deal with that first. All those in favor of approving all 7 topics, please signify by saying aye. Aye. Those opposed? Nay. Motion is defeated. Mr. Gordon Wilson, do you wish to make a motion to approve the 6 topics? I'll let you make the motion.
I'd like to make a motion that we approve the 6 topics. That would be community services, funding for sexual violence, Department of Business, rural internet, middle mile, Department of Seniors, Nova Scotia's action plan for aging population, health and wellness, funding for home care, Nova Scotia Office of Immigration, Immigration Streams and Programs, and Department of Health and Wellness, Rural Health Care Delivery.
The motion, Mr. Tim Houston.
Thank you, Mr. Chair. So Mr. Wilson's motion excludes internal services, supplier contracts related to the FOIPOP breach. I don't know if maybe Mr. Wilson cares to expand on why he's excluded that topic.
Mr. Gordon Wilson.
I think I explained that in my opening comments. I did the fact that the Auditor General is looking into that at the time.
Mr. Houston.
Thank you, Mr. Chair. I'm not sure that I agree with the logic on that. The Auditor General operates separately from this committee. For sure, we respect the work of the Auditor General's office, and we often rely on it. But certainly this committee is not beholden to the Auditor General's schedule. We can call topics before this committee that we think are appropriate for discussion. And we did, at one point in the past, follow this path. We went down this road before with the IWK and the expense situation that was there. At the time, the Liberal Caucus said, well, hold on, we don't need to bring that before Public Accounts. The Auditor General's going to look at that. I think a year plus passed. I don't think we should use that. That's not a good precedent for this committee. So I would think that the Auditor General has many audits they're trying to do. They have a schedule out, and they're looking at a schedule process for many things. So if we continue down the path of allowing the government members to keep things away from the Public Accounts Committee because somebody else is looking at it. So insinuating that somebody else should look at it, this committee shouldn't, whether that be the Auditor General or an expert or whatever. I don't think that's a good precedent for this committee. I think this committee should be focused on matters of importance to Nova Scotians, irrespective of who else is focused on them. We're talking about, in this particular case, people's personal private information that was breached. That's a matter of importance for the government. I think this committee should consider. So I would like the member to reconsider his position in the interest of Nova Scotians, maybe put the interest of Nova Scotians before maybe government interests, and say that let this committee look at the matters that are of importance. So I'd ask the member to reconsider his motion and put the slate of topics that the subcommittee decided for scheduling, and let the committee talk to people who know.
We do have another person who wishes to comment. Is it the will of the committee to sit past the hour of 11 a.m. to extend the meeting for any further discussion? All those in favor signify by saying aye. Aye. Those opposed? Okay, we will sit beyond 11 a.m. as necessary. The Honourable Dave Wilson, a comment.
Thank you, Mr. Chair. And quickly, I would concur with the comments just made by my colleague. I don't believe the Office of the Auditor General is actually doing a full audit. They're working and they're assisting with reviewing what happened. And as was indicated, there's no other committee that's looking at this at the time. And I would say that with the schedule, we're looking at our schedule going into September. Some of these witnesses would be in September. So if that's the case, we could hold that that topic to the end of our schedule. And I would ask if the members of the Liberal Caucus just to reconsider and bringing this topic forward.
Thank you. The motion before the floor put forward by Mr. Gordon Wilson is to approve these 6 topics. All of those except for internal services to discuss supplier contracts related to the FOIPOP breach. All those in favour of the motion signify by saying aye. Aye. Those opposed? Nay. Motion is approved. So those 6 topics are approved. The clerk has flagged for me. We do need to formally approve as a full committee the May 30th date for the Office of the Auditor General, at which point he will be bringing forth his spring 2018 report. All those in favour of having the Auditor General as a witness on May the 30th, please signify by saying aye. Okay. Those opposed? That motion is passed. So our clerk will make note of that. I just have a couple of more items here. It won't take long. Ms. Roberts.
Sorry, this is maybe just a point of housekeeping, but I noted that in our witness package for today, the IWK was not actually listed as a witness, and you know, I think we could have gone in that direction, except we didn't actually know that they were going to be here as a witness. So just it was an opportunity missed, sort of.
Okay, point noted, and that's something we will watch to ensure that members are aware of all the witnesses who are appearing. Thank you. The next item we discussed in our subcommittee meeting, and it's for approval here by the full committee, was distribution of meeting agendas. So we came to an agreement that members and researchers for the caucuses will receive meeting agendas on Fridays before our Wednesday meeting the following week. The subcommittee also agreed that any information that is sent to members will be sent to researchers as well. I want to issue a warning. If you have researchers in your office that leave your office, the onus is on committee members to ensure they are removed from the distribution list. Otherwise, we have information for the committee leaving, going outside of the committee's interest, and that would be considered a breach, and we cannot have that onus put on the clerk. That onus has to be on members. So if we are agreeing to this, we are agreeing also to respecting this information. If you have somebody leave your office who is a researcher, that you notify the clerk. Mr. Jessom.
Thank you, Mr. Chair. I think you just answered my question. I just wanted to clarify what the appropriate medium of communication or who.
Sure. So the answer to that would be for your caucus, preferably through your the member on the subcommittee for your caucus to notify the committee clerk.
Excellent. Thank you, Mr. Chair.
The Honourable Dave Wilson.
Thank you, Mr. Chair. Could I ask that the U.S. Chair reaffirm that and send a letter to each of the Chief of Staff for each of the caucuses, because ultimately Chief of Staff works closely with Chief of Staff and Caucus Chair, if that's okay with the committee. And that way there we make sure that it's fully understood the responsibility of each caucus and members of this committee.
Thank you. A good suggestion, and we will send such a letter as you've recommended. So the motion, the question put before the committee is to allow, is to ensure that agendas are distributed on the Friday before the Wednesday meeting of the following week, and also to distribute agendas and research packages any information being sent to members will also go to researchers in the caucus offices. All those in favor of the motion signify by saying aye. Aye. Those opposed? The motion is passed. The next item we have, and for simplicity's sake, what was approved by the subcommittee on this issue is it has to do with briefings from the Auditor General. So for simplicity's sake, any meetings that we are having with the Auditor General, in the case of the witness appearing in relation to a report that had been made by the Auditor General, so picture a department coming in as a witness related to an Auditor General report. Before that meeting, we will have a 30-minute in-camera meeting with the Auditor General. Also, a 30-minute meeting in advance with the Auditor General in camera on days where the Auditor General is presenting a report, such as we will see on May 30th. So all those in favor of a 30-minute in-camera meeting with Auditor General before meetings either associated with an Auditor General's report that they're introducing or with a department who is a witness in response to a report of the Auditor General. All those in favor of that, Mr. Gordon-Wilson.
So I'm assuming also that the standard practice that we've put in place of having the reports come out on a Tuesday and then the meeting go on the Wednesday is part of that. And I would also add the suggestion my colleague had of adding this to that letter that was going to go out to the caucus chairs and that regarding some formalities within. Would be nice to have that, if you don't mind, added to that also.
Yes, we will include that in the correspondence as you recommended. And the answer to your question is yes. So all those in favor of the motion, please indicate by saying aye. Aye. Those opposed? So that motion passes. Our final item here is we do need the appointment of an acting chair for the May 9th meeting. Nor myself nor the deputy chair of the committee can be here on that day. Would anybody like to, Mr. Gordon-Wilson?
Yes, I'd like to suggest Suzanne Lonas-Croft fill that position that day.
All those in favor of Ms. Lonas-Croft being the chair for the May 9th meeting, please indicate by saying aye. Aye. Those opposed? The motion is passed. We have an acting chair for the May 9th meeting. So our next meeting is May 2nd. We will have the Department of Finance and Treasury Board and the Nova Scotia Liquor Corporation to discuss listing of local products and new products. Is there any further business to come before the committee?
Mr. Chair, can I ask a quick question?
The Auditor General's office, Mr. Spicer.
Can we assume those briefings will be in-camera briefings?
Yes, they will.
Okay.
Yes, they will.
Thank you.
Okay. Any further business to come before the committee? Hearing none, this meeting is adjourned.